Good afternoon, everybody, and welcome to the Cranial Dystonia, Blepharospasm and Oromandibular Dystonia, an Alternative to Meige Syndrome webinar with our featured speaker, Dr. Joseph Jankovic. Just so that you know, this webinar is being recorded. If you have questions that you would like to ask during the webinar, please submit those questions through the Q&A icon at the bottom of your screen. For the Zoom icon that's down there. Before we get started, and in order to give people time to sign in, because a lot of people are attending their very first Zoom anything, I'm going to take just a little bit of time and talk about what's going on with the foundation, BEBRF. This is our 40th birthday / anniversary year. So we're very proud of that. We've been celebrating it all year long. But I just kind of want to give you an update on what's been going on, particularly as we might have been affected by the pandemic, etc. First of all, our mission statement is a three-part mission statement. We involve ourselves in research, support, and education. Research to find a cure, support because we care, and education to enlighten. As far as the research goes, to date, BEBRF has funded almost $3 million towards research. And this has been funded almost entirely by donations from our patient base. Research grants are decided by physicians and researchers on the Medical Advisory Board. There have been over 70 research projects that we have funded over the 40-year period. For support, we have a nationwide network of support groups. Now, in a non-pandemic time, these meetings happen in person, and people get to share and counsel each other through what their experience with blepharospasm is. Because of the pandemic, it led to the creation of our Zoom support group meetings. These have been extremely successful. We will be continuing them even after we go back to in-person meetings, which we will be doing in the very near future, having in-person meetings again. We have several on the schedule already. But there are a lot of people who don't have a support group leader who lives anywhere near them, or they may not have transportation to get to a support group meeting. So for those people, we will continue to have the Zoom support group meetings. We maintain a national database of treating physicians here in the United States. So if you're looking to find a doctor, if your doctor retires, sadly passes away, or just moves away, we can help you find a new doctor. Just contact us. We also do advocacy on the national and local levels. What that means is that we go to Washington, D.C. and talk to Congress people and senators and advocate for things that are important to blepharospasm and dystonia patients, making sure that enough money is funded for research, that things like insurance issues are handled appropriately through the congressional level. For education, we do a lot of things educationally. Every year we have an annual symposium, except for 2020, obviously, because we had a pandemic. But we are going to have one this year. It's usually held in a different city. If you're unfamiliar with the symposium format, it's a day-long session where doctors who are experts in their fields give us updates on everything blepharospasm and its related disorders. So if you can come, please try to make it. During the pandemic, however, since we were unable to have our symposium, we instituted our webinars. I think this is our 5th or 6th webinar, and they're all recorded, just like this one's being recorded. They're all recorded. They're available through our website on our YouTube channel. So if you want to go back and see one that we've already had, or if you want to rewatch the one you're seeing today, just go there and you'll be able to do that. And we're going to continue the webinars into the future as well. We put out a quarterly newsletter that is just full of useful information, up-to-date information about treatments, about research, about patients who are sharing their stories of what's worked for them, etc. It's a really great newsletter. Make sure that you're signed up for it. In our office, And we have a vast collection of research, articles, brochures, and other materials. We have brochures that one's called How to Talk to Your Doctor. There's another one that's called Helpful Hints. That's all the little tricks that people have learned over time that helps them cope better. We have a brochure that's called Blind but with Perfect Vision. That one is the one you give to people who can't quite seem to understand what's going on with you. It explains it very well. So check out what kind of brochures we have. We have a website, and here's the really great news. We're going to have a new website very soon. We're very excited about that. Lots of information there. We attend national medical academies. Right now, it's still average for a patient from the onset of symptoms until diagnosis for that period of time to take up to 2 to 5 years, because we just need to do more education to doctors. So to that end, BEBRF attends national medical academies in order to spread the word to doctors so that they'll at least be familiar with blepharospasm. They may not be the person who ends up treating the person with blepharospasm, but they will be able to possibly recognize it when they see it. Okay, again, this is the Cranial Dystonia, Blepharospasm, and Oromandibular Dystonia, an alternative to Meige Syndrome webinar. Please submit your questions through the Q&A. And now I would like to introduce Dr. Jankovic. Hold on one second. Dr. Joseph Jankovic is a professor of neurology, distinguished chair in movement disorders, and founder and director of Parkinson's Disease Center and Movement Disorders Clinic. He is a neurologist at Baylor College of Medicine in Houston, Texas. Dr. Jankovic has served as the principal investigator in hundreds of clinical trials and has led pioneering research in etiology, that's the study of the causes of disorders, pathogenesis, which is the study of the progression of disorders, and classification of various movement disorders, and on experimental therapeutics, as well as contributing to classifications, characterization, and therapeutic guidelines of various movement disorders. His research on drugs for Parkinsonian disorders and hyperkinetic movement disorders, including botulinum toxin and tetrabenazine, has led to their approval by the United States Food and Drug Administration for therapeutic use. Dr. Jankovic was awarded the very first research grant funded by BEBRF back in the 1980s, and he has served on the medical advisory board for decades. In other words, you would be hard-pressed to find any doctor in the world more qualified to speak on cranial dystonia. So it is with great pleasure that I introduce Dr. Joseph Jankovic. Hello, Dr. Jankovic.
Hello, let me make sure I have my slides ready. Okay, I hope everyone can see my slides. Is it right?
Yes, yes,
okay,
we can.
Good. Well, thank you, Charlene, for the wonderful introduction. And I'm delighted to spend at least part of the afternoon with the participants in this webinar. I hope that we will soon see each other in person. So the topic that was assigned to me today is somewhat complicated and long title, but I will go through this topic in some detail, but still hopefully finish on time so that we'll have plenty of time for Q&A. So blepharospasm has been recognized for centuries, if not millennia, and we know that it was depicted in various pictures. This is an example from Leonardo da Vinci's studio, where he and his student depicted this man with the eyes shut. We don't know whether he had blepharospasm, but obviously it had forceful closure of the eyes, which is a characteristic feature of blepharospasm. Here's another example of blepharospasm in the arts. I took this picture when I was in Vienna this is by Messerschmitt, a famous Viennese sculptor who specialized in these faces, showing, for example, here a man with blepharospasm as well as spasms of other facial muscles. And then in the 16th century, Flemish artist Bruegel first depicted this woman who might be yawning, but more likely has some involuntary jaw opening, but also some blepharospasm. And this painting became particularly famous in the medical literature when David Marsden, one of the founders of our field in movement disorders, first described blepharospasm, Oromandibular Dystonia, and he used the term Bruegel syndrome to give credit to this Flemish artist Bruegel, who depicted this woman. But the main finding from this particular study and this paper was that David Marsden, was the first to characterize blepharospasm as adult onset focal dystonia. And we're going to spend some time talking about dystonia. So blepharospasm was first described in the medical literature by Horatio Wood, who was a professor at the University of Pennsylvania. And in his original description, he stated that the facial convulsions are in some cases limited to isolated muscles. The orbicularis palpebrum is especially prone to suffer, giving rise to the affection known as blepharospasm. So he was the first one to coin the term blepharospasm, meaning contraction of eyelid muscles. The contractions may be tonic, which means sort of sustained, or causing complete closure of the eyes. And this is accompanied by bizarre grimaces and various other contractions of the eyelids and other facial muscles. Now, the eponym Meige Syndrome was named after the French neurologist who first reported facial spasms in a series of papers in 1910, mostly occurring in women in Paris and France. And he clearly described these contractions of the facial muscles, including eyelid muscles and jaw muscles. But since Henry Meige was not the first to describe this combination of facial contractions, blepharospasm and oromandibular dystonia, it was reported, as I noted, by Horatio Wood 23 years earlier. The generic term cranial dystonia is really the most appropriate term for this condition that is manifested by blepharospasm and lower facial or jaw spasms, so-called oromandibular dystonia. So blepharospasm means dystonia. And so what is dystonia? Dystonia is a neurologic disorder that is dominated by involuntary, sustained, or spasmodic, repetitive, or pattern contractions of muscles, frequently causing twisting, squeezing contractions, such as blepharospasm, or other abnormal movements or postures. But again, the characteristic feature is the pattern contractions, meaning the same group of muscles is contracting each time. So blepharospasm is considered a form of focal dystonia. It is often combined with oromandibular dystonia and also neck dystonia or cervical dystonia. And the term cranial-cervical dystonia is used to describe this combination of blepharospasm, oromandibular dystonia, and cervical dystonia. Now, cranial-cervical dystonia is often wrongly referred to as benign essential blepharospasm. And I have always had problems with that term, but in the literature, it is often used, not as frequently as in the past. And as you know, it is part of the name of our foundation. And I'll come back to that later. The term Meige Syndrome is sometimes used, but again, it's a wrong term for this condition. And we talked about Bruegel syndrome. So I would strongly encourage you from not using the terms benign essential blepharospasm, because there's nothing really benign about a blepharospasm. It's certainly not essential. I think all of you who have blepharospasm certainly can live without it. And I explained why Meige syndrome, Bruegel syndrome are not appropriate as well. So the term cranial dystonia should be used when only the facial muscles are involved, and cranial-cervical dystonia should be used when facial and neck muscles are involved. So how common is dystonia? This is taken from a review article on the epidemiology of dystonia, and what you can see is that in this review, primary dystonia is estimated to occur in 16.4 people per 100,000. And if you look at the subsets of dystonia, namely cervical dystonia, it occurred in 5 out of 100,000, and blepharospasm, which is probably the second most common form of focal dystonia, occurred in about 4.2 per 100,000. So it's not a common disorder, but it is clearly a disorder that can be very troublesome for patients, and in some cases even disabling. If you really want to learn a lot about dystonia, there's a review article we published in this very prestigious journal about 3 years ago, and you can Google my name and Nature Review disease primers, and you will find this article. So a few years ago, a number of experts in the field of dystonia got together over a period of several months or possibly years to formulate the definition of dystonia and to suggest classification of dystonia. So I'm not going to go through this in any detail, but again, we define dystonia as a movement disorder characterized by sustained or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. As I pointed out before, the contractions are patterned, meaning the same muscles are involved. And there are some forms of dystonia, such as blepharospasm and laryngeal dystonia, which are not due to twisting movements, but are due to contractions of the individual muscles. And we divided the classification into clinical characteristics and etiology or cause of dystonia, but I'm not going to go through those in any detail. So blepharospasm usually starts as increased frequency of blinking. Many patients complain at a time of photophobia or light sensitivity. They then developed intermittent contractions of the eyelids. Usually it's bilateral, but maybe asymmetrical. And eventually it results in the sustained closure of the eyes, which interferes with the vision despite normal visual acuity. The dystonia may affect not only the eyelid muscles, but may affect the other muscles of the face and jaw, including the tongue and then neck in the case of cervical dystonia. Or larynx, and the term spasmodic dysphonia is often used to describe a condition of laryngeal dystonia that can cause very sustained, strained voice or other voice abnormalities. And sometimes the dystonia can spread from the face and neck to other parts of the body and becomes generalized. Dystonia may be painful, but not always. And even though the visual acuity is preserved, the patients clearly have an impaired vision, resulting in difficulties reading, watching TV, driving, and performing activities of daily living. So the blepharospasm is often triggered or exacerbated by bright light, wind, or any kind of movement. It is better when the patients are concentrating or when they are looking down, or worse at rest while looking up. And it is often relieved by wearing dark glasses, and many patients with blepharospasm wear dark sunglasses, not just outside, but also indoors. There are a variety of alleviating maneuvers that patients learn to adopt, which are sometimes referred to as sensory tricks, or with the French word geste antagoniste. And these include pulling on the upper eyelid, touching the forehead or eyebrow, pinching of the neck, humming, coughing, yawning, talking, singing. So I'll show you an example of a patient who made the observation that when she sings, her eyes can remain open. It may progress rapidly over a period of weeks or months, but usually it takes several years to fully evolve. It tends to progress initially, but then it tends to stabilize maybe after 4 or 5 years. Some patients do undergo transient remissions, and I'll come back to that later. Because there's so much fluctuation in the severity of the dystonia, of the blepharospasm, it's often thought to be stress-related or hysterical or conversion or psychogenic or functional. Those are some terms that are sometimes used to misdiagnose, frankly, blepharospasm as a psychological disorder, even though it's a neurological disorder. So it's not even an ophthalmological disorder, it's a neurological disorder that is not psychological and it is not ophthalmological. Now, there are many conditions that look like blepharospasm, but are not blepharospasm. For example, ptosis refers to drooping of the eyelids, usually due to weakness of the eyelids. There are some patients that have what's referred to as apraxia of eyelid opening, where they are just unable to open their eyes, so they don't necessarily have involuntary closure of their eyes, but they have difficulties opening their eyes after they are closed. This condition, apraxia of eyelid opening, is very important to recognize because it may potentially interfere with excellent response to botulinum toxin. So here are some examples of alleviating maneuvers or sensory tricks, like elevating one eyebrow, touching the eyebrow, using these sunglasses, a number of other factors. So here's a patient who can open her eyes when she sings, and that's her alleviating maneuver.
I'm sorry, I can't see.
How many have symptoms?
This is getting close to 3 years.
Can you hold it open?
If I sing, maybe. I don't know.
You drive?
If I sing.
Can you go in and sing to see what happens?
One day at a time, sweet Jesus, that's all I'm asking from you. Just give me the strength to do every day.
So you could see that when she sings, she was able to keep her eyes open. Again, it's an example of a sensory trick or alleviating maneuver. So many patients with blepharospasm also have spasms of other facial muscles, particularly the jaw. And when the jaw is involved in this dystonia, it's referred to as Oromandibular Dystonia. So it's usually manifested by involuntary closure or clenching of the jaws, sometimes associated with grinding of the teeth. And we use the term bruxism to describe this closure of the jaw that can result in dental damage. And also it causes pressure on the temporal mandibular joint and causes the TMJ syndrome. In fact, in my opinion, the most common cause of TMJ syndrome is oromandibular dystonia, often associated with bruxism. Sometimes patients with oromandibular dystonia, instead of having jaw closure, they have jaw opening or deviation. It may be associated with difficulty chewing, eating, and speaking. In patients who have tongue dystonia, the tongue may push the food out of the mouth, and this certainly can interfere with eating. There are many other symptoms that are often associated with oromandibular dystonia, including weight loss, partly due to difficulties chewing and swallowing. Dystonic respiratory dysregulation refers to a condition where patients with oromandibular dystonia have difficulties breathing, and they may have shortness of breath because of irregularity in their ability to inspire and keep their larynx open. And many patients also have involuntary vocalization, such as humming, grunting, belching, and gasping. So many patients with oromandibular dystonia initially present with blepharospasm, and subsequently the blepharospasm spreads from the eyes to the lower part of the face. So there have been many studies on oromandibular dystonia. I just wanted to highlight some recent studies that in this particular case, this study involved 240 patients with oromandibular dystonia. They had a mean age of 52 years, but the onset could have been as early as 3 years of age or as late as 85 years of age. Females outnumber males, and some patients had family history. In this particular study, only 2.5% had family history, but in our experience, the family history is usually much higher. The cause of oromandibular dystonia is often idiopathic, meaning there is no specific identifiable cause. Sometimes it could be tardive, meaning due to exposure to certain drugs, or certain neurodegenerative diseases can be associated with oromandibular dystonia. Sometimes it occurs after brief absence of oxygen or after injury to the jaw. In one study of 53 patients with oromandibular dystonia, 90% of them screened positive for Meige syndrome. Again, a very common complication of oromandibular dystonia. So here's an example of a patient with cranial-cervical dystonia, with blepharospasm, oromandibular dystonia, cervical dystonia, even involving the shoulder muscles. Many patients with cranial-cervical dystonia also have involvement of the larynx, and the term laryngeal dystonia is used to describe this condition. So these patients may have contraction of the vocal muscles, causing the strained voice. They may have a voice tremor. They may have a condition called essential tremor, which can also involve the larynx. And then they may have what's referred to as muscle tension dysphonia, where they are trying to control their voice by contracting various muscles of the pharynx and larynx. The term laryngeal dystonia is preferable to what's used to be called spasmodic dysphonia, even though many patients with laryngeal dystonia could develop this dysphonia or voice abnormality that is due to involuntary contraction of the posterior pharyngeal or vocalis muscles. So some patients start with blepharospasm, and then they evolve into oromandibular dystonia. They may have the spasmodic dysphonia due to laryngeal dystonia or cervical dystonia involving the neck, and they may also have tremor, which can be present not only in the head, sort of a yes, yes, or no, no type head tremor, but it may also have tremor in their hands, often referred to as essential tremor. So many patients have just cervical dystonia, but some patients with cervical dystonia spread to other parts of the body, like the upper face, causing the blepharospasm, lower face, and jaw, or it may even spread to arm and hand. Or there are some patients who start with contractions in the upper lower face, jaw, hand, and arm, and then eventually the dystonia spreads from these areas into the neck. And there are some patients, relatively small percentage of patients, only 8.2%, who don't have any spread at all. So of all the different forms of dystonias that I just described, it turns out that blepharospasm is the one that is the most likely to spread from the eyelids to other parts of the body. So after a period of several years, most patients with blepharospasm tend to have spasm of other parts of the face or neck or even other parts of the body. So far, we focused on the motor features of dystonia, including blepharospasm, but it's important to recognize that in addition to dystonia, many patients have this tremor that I described, but they have a variety of other problems, including discomfort or pain, fatigue, lack of emotional well-being. They may have generalized anxiety, depression, and social anxiety. So there are many non-motor features of blepharospasm that are important to recognize. So as we evaluate patients with blepharospasm, we try to focus not only on the motor aspects of dystonia, but provide a comprehensive care that takes into account not only the motor or physical aspects of the dystonia, but also the mental aspects and their impact on health. As I mentioned briefly before, some patients with dystonia, including blepharospasm, undergo remission, meaning resolution of the dystonia. Unfortunately, that's relatively uncommon, and when it does occur, in almost all cases, the symptoms recur. So in case of cervical dystonia, about 15% of the patients undergo transient remission, but only less than 6% of patients with blepharospasm undergo transient remission. So the vast majority of patients, even if they have a remission, eventually relapse. So what the heck is dystonia? Obviously, it's a topic for another lecture. There are many hypotheses about the cause of dystonia. But just to summarize current thinking, I think most scientists and clinicians believe that blepharospasm and other forms of dystonia result from an abnormality in this part of the brain called the basal ganglia. And you see here the basal ganglia outlined in green and yellow. So as a result of abnormality in these deep brain structures, there is a disinhibition of discharges from the cortex to the muscles of the face and other parts of the body that results in these involuntary contractions. So again, it's a very brief overview of what is known about the pathophysiology or etiology of dystonia. With respect to blepharospasm, it is important to note that there are many, many muscles in the face that might be involved in blepharospasm. The most common, of course, is the orbicularis oculi here, but there are many other facial muscles, including the paranasal muscles, the muscles around the lips and jaw. I want to draw attention to this particular muscle, the tarsalis muscle of Mueller, which is also located in the upper eyelid. And the function of that muscle is to elevate the eyelid. So orbicularis oculi closes the eye, but this muscle, the tarsal muscle of Mueller, elevates the eyelid. And also this levator muscle, which is in the middle of the eyelid, also is designed to elevate the eyelid and open the eyes. So I'll come back to that later because that's very important. So we talked about apraxia of eyelid opening as another manifestation of inability to open eyes. What are some of the causes of blepharospasm and apraxia of eyelid opening? It is often seen in abnormalities of the basal ganglia, including Parkinson's disease and other Parkinson disorders. A long time ago, we described 6 patients that developed blepharospasm after they developed lesions in the brainstem, in the lower part of the brain or brainstem. Some of them had stroke, others had multiple sclerosis. And there have been many other reports of causes of blepharospasm due to structural lesions in the brain. Now, many patients with blepharospasm do have family history of either blepharospasm or other forms of dystonia or essential tremor. And that observation has led to the hypothesis that blepharospasm might be due to genetic underpinning. But despite millions of dollars spent on research, trying to find a gene or genes that cause blepharospasm, so far no genes have been found, although there have been some signals in the genome that may suggest that some patients may be genetically vulnerable to develop blepharospasm. I just want to say a few words about treatment, although that's not the main topic of today's webinar. And perhaps during Q&A, I'll be happy to address additional questions about treatment. So we talked about alleviating maneuvers or sensory tricks where patients notice that, for example, when they pull on the upper eyelid, they can keep their eyes open. And we often use various devices, including eyelid crutches, that can enable the patients to keep their eyes open. Goggles and certain tinted lenses can prevent triggering of blepharospasm by sunlight and other elements that we know can exacerbate blepharospasm. Many, if not most patients with blepharospasm also have dry eyes, so treatment of the dry eyes sometimes can help not only the dry eyes, but also the blepharospasm. In the past, we had sometimes used medications like clonazepam and other medications to treat the blepharospasm, but honestly, most of these medications are usually not effective or have undesirable side effects. So we rarely use these medications. Aproclonidine, I'm going to mention it in a minute, sometimes can be helpful, but clearly the treatment of choice for blepharospasm is botulinum toxin, botulinum neurotoxin injection. Rarely surgery such as cutting off the nerves to the eyelids, or even brain surgeries such as deep brain stimulation is used, but that is very, very rare. So here's a patient who benefited from the eyelid crutches. You can see that he has a lot of tissue, excessive tissue in the eyelid that's called dermatochalasis. So that patient would not benefit from botulinum toxin because we cannot remove this excessive skin with botulinum toxin, but we constructed these eyelid crutches, and that enables the patient to keep their eyes open. So these are the eyelid crutches. I'll give you her website where you can learn more about it and perhaps order the eyelid crutches for your glasses. I just want to mention aproclonidine because that is a medication that we investigated at Baylor and found it to be quite effective. This drug, which stimulates what's called adrenergic receptors, also activates this superior tarsal muscle of Mueller that I mentioned earlier. And by activating that muscle, it enables the patients to keep their eyes open. So it's a very helpful treatment, particularly in patients with blepharospasm who are wearing off from their botulinum toxin injection and need to be tied over until their next treatment visit. So that's a fairly effective treatment. Clearly, botulinum toxin is the treatment of choice for patients with blepharospasm as well as Oromandibular Dystonia. As you know, there are 4 different preparations of botulinum toxin. The one that is probably most frequently used in the United States is onabotulinum toxin or Botox. Apobotulinum toxin or Dysport is another formulation used mostly in Europe. Incobotulinum toxin or Xeomin is sometimes used in the United States and in Europe. And rimobotulinum toxin is the type B botulinum toxin in contrast to the other formulations that are type A, and that is rarely used unless patients develop resistance to type A. So the muscles that we often inject are the muscles like the procerus muscle that cause the frowning and corrugator muscle. But the main muscle that we target with botulinum toxin is the orbicularis oculi muscle, which involuntarily contracts, and by relaxing the muscle, the patients can keep their eyes open. I mentioned bruxism as a form of oromandibular dystonia, which is a very disabling condition and major public health problem because it can cause not only temporomandibular joint, but also can cause dental problems when untreated. In this study, it was published about 3 years ago. We randomized the patients to receive botulinum toxin injection into the jaw muscles or placebo, and we concluded that this treatment is very effective in treating bruxism and preventing some of these secondary injuries to the TMJ or to the teeth. So that was a very effective treatment that we demonstrated by by polysomnography, meaning EMG during sleep, We believe that botulinum toxin injection into the masseter or temporalis muscles can be very effective in treating this condition called bruxism. So I want to conclude by paying tribute to our founder, Meige Syndrome, who obviously should be credited for recognizing the importance of blepharospasm and for initiating Blepharospasm Foundation. I was fortunate to know her not only as a patient, but also as a friend, and helped her start the Blepharospasm Foundation, which is something that I consider as one of my greatest honors. Also knowing her daughter, Mary Lou Thompson, also has been a tremendous honor, because Mary Lou Coster called me her son. So Mary Lou Thompson, by definition, is my sister. And I, again, want to recognize Mary Lou Thompson's contribution to the Blepharospasm Research Foundation. These are pictures that were taken from the last in-person meeting that I attended. It was in Denver, Colorado, where a number of speakers were invited to talk about various aspects of blepharospasm. And here you can see again Mary Lou Thompson and other leaders in the field of Blepharospasm Foundation. This is the current website, and I'm glad that the foundation is considering completely revamping the website, because I'm not entirely happy with the current website. So hopefully the new website will be more comprehensive, more user-friendly. And I look forward to reviewing the new website hopefully soon. But for the time being, blepharospasm.org is the URL for the Blepharospasm Foundation. So I hope that many of you will come and visit us in the McNair campus right here. Our offices, clinics are on the 9th floor in the middle of the Texas Medical Center, which, as you know, is the largest medical center in the world. So I look forward to meeting many, if not most of you in person. So thank you for your attention, and I'll be happy to address any questions you might have. Thank you.
Thank you, Dr. Jankovic. That was very, very enlightening. Yes, we do have some questions. I'm going to just read this one off. Although I receive Botox, I clench strongly now when I speak. Have you seen that and had any success in treatment allowing better speech?
Well, that's what I was talking about when I discussed Oromandibular Dystonia. So in addition to blepharospasm, patients may have spasms of the lower jaw with clenching and grinding of the teeth. And that is referred to as Oromandibular Dystonia, which can be effectively treated with botulinum toxin injections.
Yeah, but okay, let's see. I have recently been diagnosed with glaucoma, as the test I had to do was very difficult to do due to the spasms. And the doctor, when I told him about it, he did not listen and still prescribed drops for this. Your input would be appreciated. And she adds that she's had a bilateral myectomy, but still has spasms in the lower lids. So started Botox with terribly inconsistent results. So she stopped.
So myectomy is a procedure that used to be done quite frequently, but frankly is done very infrequently or rarely today. It involves excision, removal of muscles from the eyelids surgically. And unfortunately, many patients who have myectomy might initially improve, but almost all of them later develop blepharospasm again, and many of them require treatment with botulinum toxin. Unfortunately, those patients who had this prior surgery, when they are injected with botulinum toxin, the injection can be quite painful because of the scar from the myectomy. So we frankly rarely recommend myectomy today, because I think the vast majority of patients can be treated with botulinum toxin. The other point I want to make with respect to this question is that when patients require some kind of a examination or procedure for their eyes, for example, checking for glaucoma or maybe having cataract surgery. I think it's very important to time these procedures so that they are done at the optimal improvement that patients have after botulinum toxin. So I often recommend my patients to have these procedures done perhaps like a month after the botulinum toxin injection. So it's much easier for the ophthalmologist to examine their eyes because the eyelids are most relaxed during that time.
Okay. Your thoughts on zinc and marijuana?
So there's some suggestion that zinc may possibly enhance the effects of botulinum toxin. I don't prescribe zinc to my patients, but there's some literature to suggest that zinc may possibly enhance botulinum toxin. Marijuana, one of the most frequently asked questions, what do you think about marijuana? There have been no studies done on marijuana and blepharospasm. Marijuana has a sort of a non-specific relaxing effect, just like anti-anxiety medications. So it may relax the patient, may reduce some of the effects of stress on the blepharospasm. Marijuana may have some beneficial effect, but obviously we cannot prescribe marijuana for blepharospasm because it has not been approved for that condition.
Here's a question. I have a mouth guard after my blepharospasm spread to OMD to prevent my clenching from damaging teeth. When I wear it, sometimes in the Botox cycle, my speech improves slightly. Have you seen that before?
So night guards are frequently prescribed, particularly by dentists and oromandibular surgeons, to protect the teeth from damage due to the bruxism, the grinding of the teeth. I rarely, frankly, recommend it because the bruxism can be treated very effectively with botulinum toxin. And if we take away the source of the clenching and the grinding, mainly involuntary contraction of the jaw muscles, then perhaps you don't need the night guard. The night guard is strictly to protect the teeth. It is not really a treatment for the oromandibular dystonia.
Okay. Let's see this one. A therapist with a doctorate said hypnotherapy can help with hoarding if no brain lesion. What brain screening is needed to ID brain lesion for blepharospasm?
So we don't usually do any kind of tests in patients with blepharospasm. The diagnosis is based on clinical evaluation. Imaging studies like MRI scan is almost always non-productive, and we rarely ever order these kind of tests. So unless there's some atypical feature associated with blepharospasm, such as some loss of sensation or weakness or Parkinsonism or some other neurologic abnormality, we don't really order imaging studies or any other studies in patients with blepharospasm.
Can you give a definition for spasmodic torticollis?
So spasmodic torticollis is synonymous with cervical dystonia. So it's exactly the same thing. So the term cervical dystonia is sometimes referred to as spasmodic torticollis. They are exactly the same.
Okay. Let's see. Here's a question. I had a big problem with a mental fatigue or a kind of brain fog where I just wanted to rest or lay back. Gradually, I could fight off symptoms by taking a short nap or by exercising to induce a sweat, and then the fatigue symptoms disappeared. Do other patients have this problem?
So fatigue, certainly can accompany blepharospasm, partly because, it requires a great deal of physical and mental effort to keep the eyes open. So some patients do develop fatigue as part of the condition. But again, with effective treatment of the blepharospasm, usually the fatigue resolves.
Okay. I had a problem with my epiglottis not closing when eating or drinking, causing a coughing spell. An ENT said it should close automatically when the body detects food or liquid coming down the throat. Is the epiglottis connected to the same facial nerve involved with cranial dystonia? Do other patients have this problem?
So that is rarely seen in combination with blepharospasm and oromandibular dystonia. I mentioned the term dystonic respiratory dysregulation, where patients have irregularity of contraction of the vocal cord, but it can also involve the pharyngeal muscles, the muscles in the back of the throat, including the epiglottis. So that could be part of this condition called oromandibular pharyngeal dystonia. Again, it can be treated medically, sometimes, using botulinum toxin.
Okay. Has Artane been helpful for OMD? Are there any new drugs on the horizon for those where Botox has not been fully effective?
So Artane or trihexyphenidyl is in a class of drugs called anticholinergic drugs. These drugs have been used, in the past for the treatment of tremor associated with Parkinson's disease and a number of other conditions. And before the advent of botulinum toxin, we used to use Artane quite frequently in patients with mainly generalized dystonia, not just focal dystonia like blepharospasm or oromandibular dystonia. So in patients who, for some reason, don't get adequate response for botulinum toxin, Artane could potentially be beneficial. But unfortunately, Artane can cause a variety of side effects, including dry mouth, problems with thinking, memory, bladder problems. It has so many side effects that I rarely ever prescribe Artane.
Okay. I am currently receiving injections, and lately I am experiencing pain on the right side and in my right eye. The eye doctor can find no problem. Can this be from my injections?
Well, again, I cannot answer any specific questions since I have not examined you. So you really need to talk to your doctor about it. There are many reasons why sometimes botulinum toxin injections don't work or are associated with pain or some other complications. But that's something that you're going to have to discuss with your physician.
Okay, let's see. I hear there is a longer lasting Botox being developed. Any idea when it might be approved by the FDA?
So the person is referring to a formulation of botulinum toxin called doxybotulinum, which is a formulation of botulinum toxin that we are studying at Baylor. We just completed another study. Hopefully that's going to be the final study before we can apply for FDA approval. So I'm reasonably optimistic that doxybotulinum toxin will be approved sometime next year. The data suggests that it might possibly have a longer benefit than Botox or some of the other currently available formulations.
Okay. Let me see if there are any other questions. I do believe those are the last questions, Dr. Jakovic. Thank you so much for spending this time with us this afternoon and for sharing this wealth of information that you have. And we really appreciate it. Thank you.
Well, thank you. And hopefully we'll get to see each other in person soon.
I hope so.
Okay.
Okay, I just have a few closing things that I would like to say. Okay, coming up in the rest of 2021, well, help us celebrate the EBRF's 40th birthday. I will mention we are in the middle of our mid-year appeal right now, so give us a birthday present if you can. We're going to be unveiling probably within a month to 6 weeks our brand new website, really 21st century. And we have been working very hard to transform our Facebook page to be a beacon of information. So if you're ever looking for what's going on with blepharospasm right now, where we are with certain treatments, what all kinds of ask the doctor questions, all kinds of patient stories being shared on our Facebook page. So check it out. Now, if you go to our Facebook page and you hit like, that will make our Facebook posts show up in your personal feed. So please try and do that. Mark your calendars on Friday, July 16th at 1 o'clock Central Time we're going to have a Cranial Dystonia Zoom support group meeting so that we can sort of unpack what we've learned here today and talk about it a little bit more in length with each other. So if you would like to go to that support group meeting, you can email me, Charlene at blepharospasm.org, and I'll make sure that you're on the list to get a link into that support group meeting. And then finally, we have our symposium is October 8th and 9th. In Philadelphia. Dr. Jurij Bilic is the program director, and this is a really exciting symposium, a lot of different topics that we normally have. And at the end of the day, we have a patient panel where patients are going to talk about various alternative therapies, like neuroplasticity training, dry needling, Reiki massage, all kinds of different things that people are trying. And we're going to try and be really realistic about if they are, how often they're successful, how often they're not successful, and so forth. So that's kind of exciting, I think. And then, let me see, did we have one more question that came in? Oh yeah, the symposium is free. We feed you and everything. You will have to pay if you stay in the hotel. You'll have to pay your hotel fee, but the symposium is free. And then don't forget, your donations make programs like this possible. So please give as much as you can, and we'll continue to create and expand our programming to help you. Thank you very much for joining us today. And I hope you have a wonderful rest of the weekend. Take care.